Thank you to everyone. Okay, we're ready for our panel. This is going to be the last session of the day. Thank you to everyone for spending this day with us. I think you'll agree a lot of great information presented. Thank you to the online audience as well as those here. I would like to invite our panelists to come to the panel table and our moderator to come and introduce himself and how he will be moderating this final panel.
All right. I'm Dr. Jeff Harris here in Memphis, and looking forward to hearing these answers to questions. Had some very good online questions presented. Please continue to present online, and they'll pass those forward as we go. But I thought we had a wonderful day so far in this amazing room. It's my first time being at a conference at this particular venue. It's quite nice. Are there any burning questions in the room? Well, we can start off, Dr. Chandler. Someone commented on your wonderful presentation and cringy feeling and all. So your 15-year-old daughter gets the shout out there. They asked, for AML, what was the lowest platelet count you've started venetoclax on?
So I don't know if there's an absolute number, but 10,000, I'll transfuse them and start it. You kind of have to treat through. You have to get their disease under control before the platelets, or else, if they're low to start with, they're not going to get any better unless you treat them. So.
Excellent. Dr. Mitchell, I have a question for you. Is there a group of patients with a stage 3 resected colorectal cancer that you wouldn't recommend adjuvant chemo if their ctDNA was negative post-op for stage 3?
Not for stage 3. Stage 3, for stage 3, the recommendations are adjuvant post-operative chemotherapy unless there are comorbid conditions that preclude giving chemotherapy. Now remember, the majority of patients with colon and rectal cancer are over age 72. And what that means is that these are also patients who may have other medical problems. Also remember that African Americans have a 20% higher incidence of colon and rectal cancer. And again, there could be hypertension, diabetes, and other medical comorbidities that would affect the institution of chemotherapy. But I would not use a ctDNA to make a decision on adjuvant chemotherapy for stage 3.
Thank you.
Hey, can I ask Dan a question? I thought of this when you were having your discussion. Okay, so when you talked about the castrate-sensitive metastatic prostate cancer, and I'm speaking out of my area, a wheelhouse, so bear with me. So it looks like whenever you add 3 agents, at least in the high-volume disease, it had an impact in overall survival. I feel like in most of the diseases I treat, most of the time the overall survival kind of levels out. Like you can eventually reflex back to each drug and add them on at the end. So do you feel like those patients just get sicker and can't move on to the next line, or do you think there is something biologic about adding all the agents up front?
Yeah, no, that's a great question. Remember, prostate cancer can have a long natural history, so one possibility is that, those trials, you have I think, on that study, 4 or 5 year data where you've seen the OS at that point. Maybe because prostate cancer has a long, natural history, when you have a 10-year update on OS on the study, maybe the curves will not be so much. But the impression has been from all the other prostate cancers.
It was overall survival curves, right? Okay.
Yeah, but again, there's no 10-year data on the study. There's already a difference, but will the curves get
Okay.
closer over time? We don't know. Because people can survive a long time. Yeah, but the impression has been from all the other studies, when you bring things earlier in prostate cancer, that biologically there was something about it that we don't understand. Yeah, I don't think we know the answer to that question. It is definitely true, as you know, that patients get more frail over time. It's an older population, so there is some attrition in terms of men who are in their 80s, 85, not being able to get docetaxel. So it is more guaranteed that they will get it sooner rather than later. So,
Great.
yeah.
The follow-up on that, actually, you didn't have a chance to talk about irradiation of the prostate in metastatic castrate-sensitive, as a la Europe, the European regimen are kind of cytoreductive. What's your take on that?
Radiating the primary for patients with metastatic disease?
Prostate.
Yeah. So the STEMPEDE data supports that. We try to do it. I mean, I refer my patients to Dr. Gishin from radiation oncology for the patients with low burden disease. So we believe the data. I think the data was convincing enough from STEMPEDE to justify doing that. The challenge that I see sometimes is even I've had several patients in this situation that even with low burden of disease, sometimes they have such a huge prostate or a huge locally advanced disease that they are not candidates for a more definitive approach to the prostate. Because, I mean, if you're going to do it, you want to do it in a way that mimics the STEMPEDE. You don't want to do it just a little bit to palliate, because it's not for palliation. It's really for survival prolongation if you're going to do it in that context, right? So, so just doing a little bit of dose and a little bit of field here and there just to get it done without following the STEMPEDE when the patient has no symptoms, because that's a period of time where the patient is improving from the hormones because he just started the hormones. So, so Dr. Gishin really wants to follow the STEMPEDE fields and everything, and some patients have more disease than can be radiated. We just say, we'll wait until things are smaller, but then you wait 6 months, you kind of lose that window, and then we just say, well, we'll just wait until patient has progressive disease again, and then we got to palliate. So it's a different philosophy. So, but yeah, we tried to follow that data. I think most people believe the STEMPEDE data for low burden of disease.
All right, and then on cytoreduction for renal cell, where are we with that? Are we doing that at all anymore?
No, we're not. So the data with TKIs was mostly underwhelming. The degree of cytoreduction is relatively modest, and there's never been any survival benefit. So it's mostly been a discussion about, the patient is going to be a difficult surgical candidate, and you can we cytoreduce a little bit to make it happen, to make the surgery happen without any other proven oncological outcomes. The cases where this comes up the most are those very complicated cases where there is a stage 3 case with a huge tumor thrombus in the IVC, where it's going to be a commando operation to get all that IVC thrombus out. But so you do have some patients that you get shrinkage, but majority don't. So you got to do it on a case by case basis. Now, all that data was mostly with TKI, the VEGF TKI data. Now that we have the IOs, we're also not seeing any significant cytoreductions in the primary. There's some small series that suggest there could be some benefit, but most of the time we're not doing it. The Prosper study, which was a neoadjuvant study with nivolumab, was actually a negative study, resulted last year. It was a study where they gave nivo pre-op and also post-op. So it was sort of an adjuvant trial, but it includes neoadjuvant nivo, and it was a negative study. That was disappointing. So, so in a general sense, we would not do any neoadjuvant in that setting. The only situation where you could envision doing immunotherapy prior to surgery is if you're going to do it in the paradigm of cytoreductive nephrectomy. So patients with metastatic disease, that you're gonna do cytoreductive nephrectomy. We used to do that a lot until a few years ago. Then the Carmina data was presented. Carmina was a large study where patients would get either VEGF TKI alone. This was in the VEGF TKI era. They had metastatic disease, they'd get VEGF TKI alone, or they would get cytoreductive nephrectomy followed by VEGF TKI. These were patients with synchronous presentation, so IMDC intermediate or poor by definition, because a good risk IMDCs, they already had nephrectomy before. So there's the intermediate poor, and then the results were negative. So in other words, there was no benefit to cytoreductive nephrectomy in the VEGF TKI era for doing cytoreductive nephrectomy. So for patients with metastatic disease, so it stopped being done. Now we're in the IO era, or the IO VEGF era, so the question is sort of being resuscitated, but it's a research question at this point. So right now, if I had a patient with metastatic disease that had a few sites of metastasis, let's say 1 or 2 lung lesions, we would, in intermediate risk, we would not do nephrectomy up front. We would start systemic therapy, IO VEGF TKI. I typically in those cases use pembrolizumab, lenvatinib, because you get the highest CR rate. So I tried to take the patient to CR. We know that the kidney will almost never be a CR, so you're hoping about CR distantly. And then after 6 months, if the patient is in CR distantly or has very minimal mets, then do the nephrectomy, try to go for a cure. There is a randomized study going on by the cooperative groups to try to answer that question, is cytoreductive nephrectomy worthwhile or not? I believe after 6 months, they get 6 months of systemic therapy, then they get randomized surgery, no surgery. But in the true sense of a new adjuvant approach for cytoreduction, there's generally no role for that.
Thank you. Dr. Seethramu, we've got to bounce it over there down to the end of the table. I wrote down so many lung cancer questions, we would run over time. This is a true story. But the first one I wanted to ask you is quadruplets for lung cancer, primary metastatic lung cancer. So platinum doublet plus PD-L1 plus CTLA-4. Are you using it? Who?
Yeah,
for
it's
whom?
a great question. It is, it's a problem of plenties that we have at this point. Dr. Porter presented studies that suggest that just immunotherapy alone is sufficient, and then we're like, there are times, yes, let me answer your question directly. It's a debate for an hour, but I do use it, and I use it in specific circumstances. There are patients who, again, if you look at the subgroup analysis, patients with liver metastases tended to do better. There are patients who want limited number of chemotherapy. They have either low PD-L1 or negative PD-L1. So I know I need to combine something with it, but they do not want to have extended courses of chemotherapy, and 2 cycles of platinum taxane seems to be appropriate in that setting. And also squamous histology, it seems to be, those are the two scenarios where I tend to use it more.
Excellent.
So I would like to offer support for what we've just heard. I don't know if you have seen, but I just finished, I think 3.5 years on the President's Cancer Panel. And a year ago in February, we recommended that physicians utilize screening for all of the cancers that we have information that screening is effective in saving lives. And that would be cervical cancer has the best track record of follow-up and adherence to screening and the diagnostics and follow-up after that. Breast cancer is second, colorectal third. And if you don't look at the curves very thoroughly, you will miss lung cancer. It's at the bottom. And fewer than 10% of patients in America who are eligible for screening for lung cancer through the guidelines adhere. And it's a combination of clinician bias, that the patients won't participate, won't come back for follow-up. But we need to work with that. And with our recommendations, we recommended that all physicians recommend to patients who have multiple risk factors and therefore need our attention. I can tell you about a patient of mine who came to me with a diagnosis of stage 4 colorectal cancer. And I looked at her pathology, went over it. She had an early stage 2 cancer, and metastases would be unusual. Well, her history was she had a GYN problem and cervical metaplasia. GYN doctor treated it appropriately and then said, well, you know, you're 45, why don't we get you a colonoscopy because you're eligible for that. She got the colonoscopy, had an early cancer, but had a lesion in the lung that was positive on PET, and she was sent to me for treatment of stage 4 colon cancer. In my history analysis, she was eligible for lung cancer screening because of her smoking history. So I had the pulmonologist and the thoracic surgeons get involved. So long story was, she had a stage 1 lung cancer. It was treated. But if that GYN doctor had not recommended follow-up for other cancers, she probably would not be surviving now. So if we all, when we see a patient, look at what the issues are, of course, for the consultation that you have, but simply ask the patients, have you had the screening for cervical cancer or lung cancer or whatever, we could save a lot of lives. So that is in the President's Cancer report that was February 2nd, 2022. And you can go online and download a copy. But if you want paper copies, just leave your name and address, and you can get paper copies mailed to you.
You know,
So,
I don't know if it's interesting. I've had patients, we definitely have a responsibility, I know all of us, to make sure all of our patients are getting all these screening, and educating primary care doctors. But we've been successful with breast in a way that I'm not sure how we learned for other ones. I've had patients that pretty much, for whatever reasons, are deciding not to pursue treatment of their cancer, like won't get this, won't get that. And then I ask them, and they'll say, yeah, I got my mammogram last week. And it's just fascinating how we've gotten it into people. It's just like, yes, I do my mammogram. I do that. And I don't know how we did it, but if, with the success to move on to other screening techniques, I don't know if it just became standard. It's just that's what you do, and there's just no question about it. So, I don't know.
well, the cervical cancer community has the best follow-up. And I think it's related to the fact that OBGYN doctors are doing that. And most people will go to an obstetrician, either for pregnancy-related care or for just routine care. They will go to obstetricians. And I think many obstetricians have almost assumed a primary care way of doing things, such that they offer other healthcare opportunities for the patients. And I think the greatest part is that the trustworthiness. And you will hear me say trustworthiness is not that the patients won't come back, and that patients don't trust. Well, that's putting the responsibility on the patient. But I think if we establish a healthcare system where we are showing the patients our trustworthiness, and therefore they can come back. So I think we have to quit blaming the patient that they don't follow up or don't come back. I think if we have the trustworthiness, they will return. And I think that's true for OBGYN doctors, that patients believe in them, that they have the trustworthiness, and patients return.
So my thoughts on this, I'm not a primary care physician, but I think, if the average patient is seeing their primary care provider every 6 months to once a year, I think this whole screening situation can only improve with some kind of systems-based practice checklist approach. Because if a patient is seeing their primary care provider every 6 months and they have to do cholesterol, a hyperlipidemia screening, diabetes screening, review immunizations, do PSA screening counseling, and then colon cancer screening counseling and lung cancer screening counseling, it's like an hour and a half visit for each patient. And I just don't see that happening. So unless it's a systems-based checklist approach where here's a checklist, are you up to date on all this stuff? I just don't know how all these other things get included in a screening visit. I just don't see the time.
Question, please.
Yeah. So, you had more questions? I don't know.
Jason?
Yes, and
Yeah, real quick question for Dr. Edith. Dr. Edith mentioned that colorectal cancer was 20% higher in African Americans. I was wondering if we know the reason why.
No, we do not. We are doing research on markers in colorectal cancer and other ideas regarding patient-oriented data collection. We don't know. And what we know, with the 20% increase in incidence rates, the mortality rates are 40%. And in fact, African American men have a mortality rate 47% higher than Caucasians. So lots of research ongoing, but we don't know. The other issue is younger patients are presenting with colon and rectal cancer. We don't know the reason why, but in the last 10 years, the number of individuals presenting with colon and rectal cancer who are younger than 45 has doubled. We absolutely don't know. Sometimes it might be related to the fact that abdominal complaints, and most of the young patients have had abdominal complaints for as long as 6 months, with attention given to the usual and common non-malignant causes of abdominal symptoms. My youngest patient was 15 at the time of diagnosis, and she had had abdominal complaints for several months and was told, well, this is what young girls go through, until she presented on a Saturday night with rectal cancer obstruction. So lots of information. We don't know why. Is it because of the diet changes in younger individuals who are spending more time in the fast food places? We don't know.
it's a question and a comment because of the comment that Dr. Baina made. I think it's really kind of a part of our culture. We just go too fast, and that really confirmed by the fast food and the dietary changes. But like, what if for work it were required for me to come with my checklist? And so we kind of put it in a place where, okay, you want me to have my checklist, then I need a half a day every 6 months to take care of these things. Because really, when do I get a chance to go to the doctor? You know, when do I have time? I'm on call right now. As a matter of fact, I'm like trying to sit here because I'm really enjoying this, but I need to go back to the hospital right now. So we don't get a chance to take care of ourselves. We work and we work and we work and we go and go and go. And, you know, every 6 months, it should be required that you have a day where you can go and get attention to some of the things that you need to address. You know, when do you get to go to the dentist? When do you get to go to have your mammogram? There's no time. Like, it's always, I have to go. And we need a checklist. We need to give it to our primary care doctor, or our primary care doctor should give it to us. And in order to continue to do anything you're doing, if your job's providing insurance, then that insurance should require that you have every 6 months some part of your screening done. Maybe we split those things into 2 visits instead of going and trying to do your lung cancer, your mammogram, your cervical cancer, all of those things at once. Split it in 2, and the first half of the year you do these, the second half of the year you do these. Everybody should get lung cancer screening. I'm gonna say that all the time. It should not be just smokers, because we're gonna miss people, just like her patient was 15 with colon cancer. I think it's gonna be hard to justify doing a colonoscopy in everybody down to age 15 or 20, but for lung cancer screening, it's just a CT scan with no contrast. And I think everybody should get one starting around age 20 to 30, you know, and maybe just once every 10 years. I'm keep talking about that until people pick it up. But we need to make time for our health, and not when we present with obstruction or when we're, you know, so run down that, you know, I'm just so fatigued, and then come to find out you have acute leukemia. You know, no, we need to make time to have our labs done and everything every 6 months, split the screenings in half, and then every year we have enough time to do it. It would only take a half a day.
Well said. I'm in favor. Thank you. And Jason, just to highlight, Jason, you guys are already doing a great job with this lung cancer screening program. How many have you enrolled so far? Because it's in its infancy, right?
It is in its infancy, and right now, personally in my practice, I've done about 15 of them in the last month. And I presented one of them last night. A husband of one of my patients who was just on lung cancer surveillance. And I asked her, well, how's your husband doing? What's up with him? Does he smoke? Yeah, he smokes. He's been smoking for 45 years. Tell him to come see me. He came in, we did a CT last Friday. PET scan was done on yesterday, and I called him with the result. It's positive. He's going to see the surgeon on Tuesday. And, you know, it's just word of mouth, really. You know, hey, have you had yours done? But, you know, if you think about it, what woman would want to go have a pap smear if we told them, okay, you get a pap smear if you had unprotected sex for this many years, and you did? No, nobody wants to do that. You feel singled out. And so for smokers, we single them out and we say, okay, if you smoke, then you get this screening. When 20% of us are going to get it whether we smoke or not. So let's take that stigma away, take away that opportunity for people to shy away from the screening and say, everybody gets it, you know, every 10 years or every 5 years, and then people don't feel singled out, and they're more likely to go in for screening.
And I would just add that, you know, it's really impressive also, in my opinion, how many family counseling issues we end up addressing just based on the somatic molecular profiling that we got from our patients. I already have, you know, in the last year or so, I know of 4 or 5 different families that we found. I mean, we found ATM, germline mutation in the patient, ended up, you know, screening all the children of that patient. This was prostate cancer patient. Had another prostate cancer patient the other day. It was a BRIP1 germline that ended up, the 4 daughters ended up coming to the cancer center for testing for BRIP1 because it has implications for ovarian cancer and so forth, and breast cancer, I think. So it's not uncommon anymore that we pick up germline things that, I mean, it takes another, I mean, it adds 20 to 30 minutes in a visit just to have a discussion with the patients and then refer them to genetic counselor. I mean, it definitely is very labor intensive, but it's happening. I mean, there is no question. And that is actually a bigger yield, right? A much higher yield because, I mean, the risk that you really have increased cancer in the family is very high. So I think that's where we can have the impact. But it's really happening, and it's not a minor thing. It's really quite.
It comes down to insurance and other barriers, unfortunately, and unless you have a program in place where you can screen all these individuals, it becomes very difficult. I have patients asking, family members asking, am I at risk? And I a lot of times I don't know the answer to that question because I truly don't know. Just to take one step before that, I'm also very, very passionate about prevention. Like, Dr. Porter said, your patient's, husband said he also smokes. That's the moment, I feel like that's a teachable moment. I really am interested in getting them to quit smoking, to quit doing things that we know can lead to cancer. So that's also, I think we lose kind of, track. We are talking about late stage, third line, fourth line, and we get very caught up with that. But I think a lot of resources need to go in. I think we are in good league today. So since you have direct connection with the presidential forum, we can probably start making some statements.
Excellent. Well, I think that should wrap up. Do we have any further online questions?
One virtual question, and it is, do any of the speakers have experience with the Gallery multi-cancer early detection lab test?
Go ahead.
Yeah, can go.
I can so I've looked at the Nature paper that kind of supported that, and it's basically DNA-based screening test from peripheral blood that looks for any evidence of malignancies. And I don't know when we'll be able to roll that out in like a screening process. We've had the discussions, and the pros, it's basically just not a shotgun approach, but it's like searching for any evidence in patients that's asymptomatic and healthy, for any evidence, the DNA indication that there might be malignancy somewhere in their body. And I mean, from the data, Nature paper, it's pretty, okay impact factor. It states that it has really high sensitivity and really good specificity. So it's not really clear. Right now, I think it's only paid for out-of-pocket cost, and insurance isn't covering it. And so I've heard both sides of it, and I at least want to be open to the idea of it. I think our knee-jerk as oncologists is, well, maybe not everyone here, is like the screening is only in these guidelines set about by the the Task Force for Preventative Medicine, and this is the how many lives saved per cost. But I think it actually might have real benefit in the future. It might have a better sensitivity and specificity than anything we're using now for screening.
I think it's definitely a futuristic tool. I'm pretty positive about that. At this time, I agree. I think, that the data is, it doesn't address a lot of things. It's not perfect. What if patients have multiple primaries, it's not going to be able to detect that. But it's also going through a rigorous training process. We're still in the process of training the AI to detect all these tumors, so we are not there yet. But I think in the future, we may have a platform where a simple blood test can answer multiple questions. It's going to happen, but at this time, we need to utilize the tools that we have, and we're not.
Sure, but one of the greatest things with this technology, one, we don't have all of the data, but we know it's sensitive. If there is a positive test and there are no other findings, including the diagnostic radiology test that we all trust in and believe in, what do you do at that point?
Exactly.
Now, one other thing that we haven't discussed, and that is the All of Us program. How many people have heard of the All of Us program? One. So, All of Us is the largest research program that NIH has not only endorsed, but sponsored. The idea came from Dr. Francis Collins, who, as you know, was the director of NIH through multiple presidential individuals over the years. So it was launched May 2018, and individuals sign on, and there is a consent form. You provide medical or clinical history information, an oral swab, and sometimes other specimens such as urine and so forth. And these are healthy individuals. It could be someone who is perfectly healthy or someone who is sick. There are no exclusions. But the idea was have 1 million individuals in the country sign on to this test. So 2018 May, so less than 5 years, there are right about 600,000 volunteers. I encourage my patients to join, and all of us. There's a website where you can sign on. But the idea is to try and deliver information to patients for risk. And it's not just oncology risk, but things like Alzheimer's and other chronic diseases, so perhaps we can learn about the risk. It also covers communities, such that in communities where there is higher risk due to contaminants in the air or the water or others, we can get information from individuals. So I am a proponent of the All of Us study. And again, you can go online. If you go on the NIH website and type in All of Us, you'll go to the webpage.
Thank you so much. And with that, we'll conclude our session today. You're going to come give some final thoughts. Thank you to our panel.
Yes, thank you all very much, and thank you everyone virtually for joining us. For those in person, we have an open bar in the back with some snacks. Please help yourself and enjoy. And again, thank you everyone. That was good.